Okay, I am Dr. Nighat Aftab. I am consultant ops and gynae working in Latifa Hospital, United Arab Emirates. Thank you for inviting me. My topic is an insight on the maternal fetal outcome of critically ill pregnant women during the second wave of COVID-19. Everybody knows that in COVID-19, the first wave, we were only astonished and we were not knowing what to do. Second wave, when it came, we have many ideas about this thing. Let me just put the slide down. Okay, so our hospital is affiliated with Medical College also, and this is Dubai Medical College and MBRU. We have no concern with any human consent was taken, and all product was according to the ethical standard, and informed consent was taken in this study. We have no financial relationship at present or previous last 3 years, and all the authors declared also same. We are acknowledge our radiology and pathology department for their help in reviewing and laboratory and X-ray findings. So what are the methods and materials we use? Actually, it is a retrospective study done in our hospital, and all procedures was done according to the ethical standards. Our study was 4 months study. It was from 1st December 2021, sorry, this is wrong, 20 to March 2021. All the data was retrieved from retrospectively from hospital database, and then we have done the plotting. All the patients that we include, they were either booked, mean they have a file in our hospital on unbooked, because we were the only hospital dealing with COVID positive patients. So all the hospital in Dubai was referring the patient to us. And their COVID-19 positive was confirmed by reverse transcriptase polymerase chain reaction. We took the age from 22 to 44 years of age, and the gestation was from 22 to 42 weeks during that duration of December 1, 2020 to March 31st, 2021. We did not include any patient whose age was less than 22 or who was older than 44, or those who are in their first and second trimester. Patient, when they were admitted to a hospital, they were closely monitored from admission till discharge after the symptoms has completely resolved and the swab test was negative. We collected various demographic parameters, including age, body mass index, nationality, prior history of travel, or any contact with the COVID-19 patients, comorbidities, gravida, parity, and gestational age at the time of delivery. We have all the noted clinical sign and symptoms, and X-ray done, and their findings was sorted out according to the severity score done by the consultant radiology. We have a scoring system was semi-quantitative. Each lung was divided into 3 zones from zone 0 to 3 based on the capacities in that zone. Perinatal maternal fetal outcome was also recorded. The antenatal ultrasound was performed, and none of the patients have any anomalies. The baby reverse transcriptase polymerase chain reaction sample was obtained when the baby born nasopharynx on the first day post delivery, and the neonates was followed closely for signs and symptoms of respiratory distress for a week. Nearly 1,184 pregnant women were reported during that period in their third trimester to our hospital. Nasopharyngeal plus oropharyngeal swab was taken, and there was 123 patients. It means 58% was positive COVID-19. Among COVID-19 patients, that was 123, we divided them into severe and mild to moderate. Mild to moderate are 93 cases and 30% was severe cases, and they required an ICU admission. This is the demographic graph. This is there. In that the mean age was, in the severe, it was 35 years of age, and in mild moderate, it was 31.7. When we take in consideration of BMI, BMI was high in severe COVID patients as compared to mild to moderate, they were 30.9. Nationalities, because UAE and especially in Dubai, it is a cosmopolitan city, so all the different country peoples are living here. Nationals, those who are UAE national, mild to moderate was more, that was 46, and severe COVID was 10. Arabs mean from different places, and those speak Arabic are 13, and 8 are severe. Subcontinent 20 and 6, others mean very far away and we cannot divide them. They were 14 and 6. Gravidas mean there was 3.4 if you take an average, or 3 points, almost the same. Parity is 2, and in the severe it was 1.97. As I told you, we took the third trimester. So at time of admission in severe, it was 33.3, and in mild to moderate, it was 36.58. Comorbidities, because when pregnant women are there, we consider their comorbidities also. The comorbidities are gestational diabetes, that is very common in this area of the world. Obesity, many people are very obese, so gestational diabetes was 16 in mild to moderate, but severe it is 8. Obesity was very high. Anemia was 7 and 3. Hypertension is also associated comorbidities. It was 6 and 1. Asthma and cough, severe cough, fever, and dyspnea. These are almost, cough was almost same and fever, but dyspnea was more and severe, and chest pain. So chest pain, then we also sorted out what are the, is any relation with the blood group. So still there is no proof, but we found that in O positive patient, there are more patients as compared to B positive and AB positive. Negative group was 5. So this was the main. In O positive, there was 32 and 6. A positive, 23 patients, and out of that is 12, and AB positive, 7 and 12, negative was 5 and 1. We have done the level blood test, mean liver function test was very important, and we have done it. ALT was very high in severe cases as compared to mild to moderate. AST was also higher in the patient with severe cases as compared to mild to moderate. Creatinine was almost same, 0.43 to 0.43. Potassium level was more higher in severe cases, that was 3.790 as compared to mild to moderate, it was 3.38. Blood cultures was negative in mild to moderate, but it was positive in 3 cases. When you compare the laboratory parameters and radiological parameters, when we have done X-ray, and I told you there was a scoring system done by the consultant radiologist. So in severe, there was 11.43 mean, but mild to moderate, it was a half, like 4.67. WBC count was 9.590, but in severe, it was higher. Platelet count was lower in moderate, but it was severe, 221 in severe. Hemoglobin was also in lower in severe, but it was a little higher in than the severe COVID. CRP, if you see, there was a vast difference. The 86 in severe COVID as compared to mild to moderate, it was 24.1. When we have asked for procalcitonin level, it was 0.6, but in mild to moderate, it was 0.09. D-dimer was almost same, rather it was little higher in mild. LDH, it was higher, 3 to 4 as compared to 170. Ferritin level was also high, 290 as compared to 93. ALT almost double, that's 47, but in mild to moderate, it was 25. AST also, when we took the meal, it was more higher in severe COVID patient as compared to mild to moderate. As we told before, potassium and this. So once we finished all these, and when we see how much are the complications, how much patient died, actually mortality was very high in severe COVID patients as compared to mild to moderate. There was no mortality. Postpartum complication was respiratory complication, again was severe in COVID, that was 10 as compared to mild to moderate. PPH was more in mild, but it was 4 in severe. The fetal distress, 24% in mild to moderate, severe was 7. Worsening COVID was, because from mild to moderate, they will become severe in 13 cases. In severe COVID, it was 18. Then hospital stay was very important for us. In severe COVID, they stayed more, 12.3, and for mild to moderate, the average was 5 to 6. These patients, because they were in their 3rd trimester and there is fetal distress, there are other causes, so we need to deliver them. So normal deliveries was in mild to moderate, nearly 55, and LSCS was 38. There are many reasons of cesarean section. It could be a previous cesarean, abruption, normal lie. But in case of severe, there was only 6 normal deliveries. Most of them are end up in cesarean section. There was a stillbirth, and that was for stillbirth in mild to moderate, but these patients came as a intrauterine fetal death. The birth weight, if you compare in mild to moderate, it was more as compared to weighted when they are improving and all, so their baby outcome will be better. What happened? Connection go? No, wait. Yes. Low birth weight was there, and Apgar is higher in the mild to moderate as compared to severe. Apgar, we take it at 1 minute, at 5 minutes and 10 minutes. So in mild to moderate, it was 8.7 as compared to severe. Umbilical cord pH is very important. It shows how much is the patient, baby is distressed and all. It is almost the same. We gave steroid before delivery, and almost it was 23 because we have a time as compared to severe this COVID. Preterm deliveries, these all patients need interference before, so we deliver before time. Staining of the liquor mean either meconium stain, blood stain. In severe, it was less than the mild to moderate. That's why they end up in more cesarean. Babies was healthy in 84, and in severe COVID, it was 26. Admission to NIC was very less, and that was 7 to mild to moderate, and severe is 4. So if we take overall, age of the patients was more than 30 in severe cases, and BMI was very high. The nationals were more involve an Arab subcontinent and other gravity I already told you earlier. I think it is the reputation. Let me wait. Sorry. Yes. I have less time now. Let me go to the conclusion. Let's see. Discussion. As you heard about this, our insight of fetal-maternal outcome in critically ill pregnant women during the second wave. Then during our studies, as we told you, the most cases out of 123, 30% 30 patients was there severe and they were admitted to ICU. And those out of that, 12 required invasive ventilation. Second wave was more deleterious for the pregnant woman. And there was more higher mortality rate in our study. And they mainly because they always selected the patient in their third trimester. In addition to this, we have all the levels of complicated cases receiving from all over the hospital with the severe COVID-19 was significantly associated with, this is from our study conclusion, higher mortality, that is 20%, and postpartum complication was also very high. Their increase overall hospital stay was more than the mild COVID positive patients. Similar studies of us shows there is a high morbidity, early cesarean section, prematurity. This is all due to the mother deteriorating health or fetal distress. It was evident in our study that neonate born to severe COVID-19 has significant high chance of prematurity, that is 76%, low birth weight, that is 46%. However, we were 4 cases of stillbirth with mild COVID. Actually, these patients came as an intrauterine fetal death. 2 cases of vertical transmission we found in mild cases and no neonatal death when they were admitted in our hospital as a live fetus, indicating that overall newborn outcome are relatively better than outcome for mother. The upper values are higher than the average rate of stillbirth, that is normally 4 per 1,000 and preterm is 6.1. Increased referral can explain the high mortality rate from the peripheral center as 3 of 4 stillbirths were diagnosed in the community and they were transferred to our hospital for their definite management. Regarding the radiology and laboratory, this was significantly high scoring. Total leukocyte count was high and hemoglobin was lower in severe cases. C-reactive protein, alanine transaminase, procalcitonin, lactate dehydrogenase, and ferritin was significantly, as you saw in the tables, was very high in COVID-19 cases. We also found increasing age and symptoms of fever, cough, dyspnea was significantly associated with severe disease. A sub-analysis of the mortality cases compare severe COVID-19 with mild COVID-19 shows less gestational age, increased duration of the hospital stay, ICU admission, invasive ventilation, higher total leukocyte count, and lower hemoglobin was significantly associated with the patient who died, and those were 6 in number in severe cases. Our study was limited by retrospective design. Additional work was not possible. Only we treatment protocol was not studied and no amniotic sampling conducted for the evidence of vertical transmission. Our conclusion is pregnant women with severe COVID have a higher mortality, peripartum, complication, increased hospital stay, and more likely to go for cesarean section delivery because of the progression of COVID-19. They were having more respiratory problems, so they need more invasive procedure. Plus, the babies are showing distress or other sign like bleeding, so we have to deliver the patient. The neonates born to such mothers may be premature, have low birth weight. Increasing age, presence of symptoms in pregnant women during their third trimester may be associated with development of severe COVID-19. Therefore, healthcare professionals caring for symptomatic patients who are relatively old should monitor these patients closely to improve overall outcome. My conclusion for a study was it was the second wave, and in this second wave, out of 123 patients, our 30 patients were severely sick, and out of that, there was 6 mortality due to respiratory problems, bleeding problem, and other problems. So it is a very short time study, but we concluded that severe second wave, it was very fatal as compared to the first wave and the or afterwards. Thank you so much.